The road of patient living with obesity is often difficult with turn, ups and downs, but actually the road to set up an appropriate care model for child with obesity is about as difficult. I put in a timeline the last decades of pediatric obesity, above in the scientific community and under in Belgium. And so I started my first consultation with Professor Malvaux in 1992 in obesity, and I read my first review on pediatric obesity treatment in 1998. This review ends with a question mark. Poor result of monotherapy, exercise or diet. Then in 2008, Time magazine asked the question, how do you cure it? And in 2009, from a meta-analysis in the Cochrane Library, emerged the success of maybe a combined multidisciplinary intervention. Okay, sorry. And then follow many clinical trials that end up in 2017 to the clinical guidelines from the Endocrine Society, confirming that combined multidisciplinary intervention can be successful for the short and the long term. And then came Smith published the developmental cascade model. We bring a larger picture of obesity, including parents, risk factors, as we have seen with Caroline. In 2001 came the concept of precision nutrition and personalized medicine. And in 2022, the Lancet published the bio-socio-ecological model, and those three highlight the complexity of obesity and of its treatment. And what about Belgium? In 2002, with Guy Massat, Jean de Schepper, Marianne van Wilkel, we met the chief of the minister office to propose a first convention project. Then we spent a lot of years and times in session with the RESIF during this year, and at the end we were a bit disappointed by the results. And finally, with Marie-Christine Le Breton, Anne Tang, and Marianne van Wilkel, we submit a pilot project with a proposition for a step care model for the treatment of pediatric obesity. We try again in 2013, supported by the Pediatric Academy. And then finally, in 2020, Zeepreventorium very bravely revived the debate by publishing a concept nota over the care of a child with obesity. And 2 years ago, together with my colleague of the BADO Pediatric Working Group, we submit to the Minister Office a document with our vision of the childhood obesity care. And so, I'm very proud. After 20 years of perseverance, I'm very proud, together with my colleague, to announce you the coming soon of the step care step care path for children living with obesity, and especially a convention for an expert center in childhood obesity. And here I would especially thank Marlène Ouagy and her colleagues from the Belgian medical insurance system who leads this working group with a ear to the ground and a very professional approach. So, when you have to take care for a patient living with a chronic disease, you have to ask you 5 questions. Those 5 questions. And the first question is, what does she have? Obesity is defined as excess of adipose tissue associated with negative health consequences. And we are used we use the BMI currently to define excess of weight. But you see, where does we have to put the cutoff? In France, for example, overweight is the percentile 91, while in USA, overweight is percentile 85. So what do we do? So in 2000, Cole and the International Obesity Task Force, IOTF, proposed an international definition of childhood obesity based on adult criteria. Overweight 25, obesity 30. They are steps in mortality and morbidity, so they are chosen for that. And so you have here the body mass index according to the age and sex, male and female. And the authors start from those cutoff, those adult cutoff, and draw back a line with a mathematical model to find BMI values equivalent to 30 of 25. For example, here, if you have a boy of 10 years old with a BMI of 24, those boy is actually in obesity. Okay, it's the same. 24 is equivalent to 30. And then they provide a table according to age and to sex with cutoff for BMI, for overweight, here 25, and for obesity. And that is those cutoff of BMI 25 that are chosen to enter in this convention. So enter door as a BMI above 20, equivalent 25, above those cutoff. But I come back to my first question. And the second, what does matter? How big or how healthy? BMI as a measure of a size and not a health. And we are all know that for same BMI, two patients may have a totally different health risk profile and complete different severity of the disease. But we wanted to tailor a step care based on the stage of obesity, providing for those with the high risk, the more intensive therapy, and for those at lower risk, less intensive therapy, by, for example, health counseling. And so BMI does not necessarily reflect health risk and functioning also, but who are two important elements for the management plan. And so when you, given the heterogeneity of this disease, obesity, the staging of obesity must not be done accordingly to the degree of adiposity, but according to the severity of the comorbidities, of the functional status and the barriers for the treatment. So we choose a new clinical staging, the EOSSP, Edmonton Obesity Staging System for Pediatrics, which is adapted from the adult EOSS. So the EOSS stratify the children in function of the severity of the risk factor, the health risk factor, the comorbidities, and the functioning. Okay, in 4 stages, from stage 0 to stage 3, and in 4 domains: metabolic, mechanical, mental, and milieu. Milieu was added to the adult score, given the importance of parents, school, and environment in the care of a child. So we have the 4M for metabolic, glucose tolerance, hypertension, lipids, mechanical or musculoskeletal pain, orthopedic problem, for mental, the psychopathology, and for milieu, the context of the child. The EOSP score is assigned as the highest from one of these M. So you take the highest, and that is the ESP score. You have here the survival rate in function of the time in an adult cohort classified either EOSP stage, either BMI classification. And you see that EOSS is a stronger predictor of increasing mortality than BMI. The classification has more on health. And for a pediatric, you have also here the EOSP stage, and here the BMI classification. You have here the number of patients, and here the percentage of the colon is a vertical reading. So, for example, here we have 41 patients with a BMI class 1, having already a stage 3 disease, okay? And in contrast, here in BMI class 3, you have only 60%, not all the patients in BMI class 3 are also stage 3. So the ESP score can help the clinician to identify patients with an increased risk who may benefit from an increased and more intensive therapy. So it's a guiding tools, and in function as a state, you have a management plan. So that's first step. Second, now, the last guidelines published in February 2033 emphasize about the complexity of obesity and the complexity of its treatment. We have already seen that with Caroline. I just put two slides, two models who emphasize the complexity of the disease. First, the bio-socio-ecological model. We may not only treat the individual, but we have to take account all the context. And the developmental cascade model. You have here the different development stage. You have here the risk factor. Caroline speaks about some. You have, for example, sleep, prenatal child health. And you have here process like adverse event, self-regulation, self-esteem, body image, that may amplify those risk factors from one stage to another stage. And those risk factors may accumulate and act as the snowball, okay? And then this model also highlights the role of family and parenting. And so treatment can be like a salmon moving up to the river. So sometimes very difficult. Obesity is one symptom of many complex challenges for the family. Reduced intervention to food and move is too short. Efforts should be relied on systemic mapping of the entire child health and family problem situation involving parents and caregivers. And remind, there is obesities and not one obesity because we have various individual situations and various physiology. So we needed a flexible, individual and personalized intervention model. And together with my colleagues, we set up this model of care according to the AOSP staging. Okay, you have the detection and prevention, CLB, PSE, quintilisine, ONA, and then you have different levels. You see that it's a very flexible model. The patient may go from one level to another level, and AOSP 0 to 1 should be treated by GP of pediatrician. If needed, with a dietist or a psychologist. In first line, the psychologists have already their own nomenclature, but we adapt the nomenclature and the reimbursement for the dietitian in first line. In the third niveau, the Zeepreventorium and Clairvaux have already their own convention, so their own financial. And for the second level, nothing exists already. So we state that we will concentrate on the second level. And given the limited amount of resources that the insurance gives us to us, we say, okay, we will start with a convention for expertise a multidisciplinary obesity childhood care center. And our plan is to set up 25 centers in all Belgium to be as close as possible to the door of the patient. Okay, this center will be composed of multidisciplinary team, pediatrician, dietitian, psychologist, physiotherapist, but be careful, only for advice and assessment, not for therapy. We plan and we would like that moving stay as close as to the door, okay? And then there was also a social worker, administrative worker, and a case coordinator. It's a bit new in all model for Belgium. This case coordinator will come from the second level and will accompany the patient and the family through all the level and through all the care path in function of the need of the patient. And we emphasize on transmission and communication, and we provide financial support to do that. One level may also ask advice to a second level. For example, first level may refer a patient with an AOSP 0 or 1 to the second level to have an advice on the management plan. And then they come back to the first level with their advice plan, and there is also a financial support for this management. And also the third level may provide advice to the second and the first level. So I would like to end up with by drawing your attention on the last point when you take care of a patient living with obesity, the weight stigma. You see here is a study. You have here the source of stigma and here the percentage, and you see that doctors are the first provider of stigmatization for patients with obesity. So it could be very harmful for the future of the patient. And so I want to emphasize we need trained professionals in patient-centered education, educated for communication skill. We should advise you have to use motivational interviewing techniques, see the family as competent to make change and not as dysfunctional, lazy, weak, willy, or I don't know why, and respect the rhythm of this family. And in conclusion, obesity is not an homogeneous disease. It is a complex disease. Diet and move is too short. It is a chronic condition. It's more about not gaining weight than losing weight, more about improving health and well-being than simply reducing number on the scale. Success is different for every individual. Avoid stigma, address root cause, and remove blocks on the road. And so, some difficult roads often lead to beautiful destinations. I thank you for your attention, and I welcome you to our annual meeting in Zeepreventorium on the 14th November. Thank you.